So thank you again for everybody coming. It's an absolute pleasure to welcome Dr. Pavardi today to speak to us. Dr. Pavardi is a very respected pathologist. She's worked 29 years on cancer diagnosis and treatment, and she's helped thousands of patients diagnosing cancer, predominantly cancers in the reproductive system, blood and lymph nodes. She's passionate about helping people understand the complex process of how cancer is diagnosed, treated and monitored. I think it's very important for people who have cancer to understand what pathology does and mean, and why results can take a long time and why they're important. Having been on both sides, I know that it can be a bit of mystery, so I think that this is going to be a very welcome talk. I'm sure that it's going to be watched for many years to come on our website. It will be on our website next week, hopefully. So if you do have any questions, please put them in the chat, and I will ask them at the end of the talk. So with all that said, I will pass over to our speaker, and let's relax and listen to what she has to tell us about getting tested for cancer.
Good evening, ladies and gentlemen. It's an absolute pleasure to be here with you all today. So I am a consultant histopathologist and has been working in this field for 29 years. So if I can just share my screen with you all. Can you see my screen?
Yes, perfect.
Okay, thank you very much. So this was the fancy title I gave to my talk, because I wanted to explain to you, patients very often don't realize the role pathologists play in the cancer diagnosis, management, prognosis, and continuing monitoring of the disease. So I I started training in pathology a long time ago. When I first became a pathology trainee, pathologists used to be in the basement. Pathology department was in the basement of every hospital, right next to the mortuary. Well, that is not surprising, because mortuary is where postmortems are carried out, and most people saw a role of pathologists as those who conduct mortuary and postmortems. The two sets of people knew better than that. The first are the surgeons. Surgeons always knew that they needed pathologists to tell them whatever the tumor was that they had excised. So surgeons always found the pathologist. The second set of people who valued pathologists were the medical students. In olden days, medical students, for the most of the year three, they learned pathology. And that's not surprising, because pathology is, in fact, scientific study of diseases. Without knowing the scientific background to a disease, you cannot diagnose it and you cannot treat it. So the discipline of pathology involves four different categories. So I was very fortunate that when I became a consultant, a lot changed. There was a new government and a new philosophy of National Health Service in UK. They were going to make cancer diagnosis, cancer survival, and cancer treatments as a mainstay of the new NHS, which meant for the cancer diagnosis, histopathologists were taken out of the basement and put on the top table. So what I'm going to tell you today is not my story of moving from basement to the top table. What I'm going to talk about today is what did we do, not just me, but thousands of pathologists like myself up and down the country. What did we do when we got to the top table? So to understand that, let me just explain a little bit about what discipline of pathology is. There are four main categories of pathology disciplines. First is microbiology. These are the people who diagnose infections, and they play a very important role even now, more so now than before, because now they advise on the treatment. So microbiologists are the people who are responsible for prescribing antibiotics and monitoring complex infection cases in the hospital. The second category is chemical pathologist. These individuals are also very involved in management of patients in the ITU to make sure all the blood samples and all the parameters are guided. The third big category is hematology, which is a little bit different from other pathologists because hematologists have their own patients. They look after their own patients and they look after patients with diseases of the blood and bone marrow. As a hematopathologist, I work very closely with hematologists because one of my big passion and big drive in life is looking at the bone marrow samples. And of course, I am a histopathologist by trade, and we are the people who do tissue diagnosis. So rest of my talk is going to be based about role of histopathology. So when we look at the different types of diseases we encounter the largest category of diseases without doubt infections. And infections, as I mentioned, is looked after by microbiologists. We can also diagnose infection in tissue biopsies. Sometimes a biopsy is done for suspicion of cancer, but it turns out to be an infection, and that does happen. The second big category of diseases that we encounter is trauma. We leave that alone. We leave that to the surgeons. But these two categories, autoimmune diseases and malignancies, are where we feature. We make the diagnosis of autoimmune disorders and malignancies. For the remainder of the talk, I'll probably focus mostly on malignancy, although autoimmune diseases are also equally important. Okay, so how do we diagnose cancer? What happens to a patient when there is any suspicion of cancer? I think the first port of call in England and United Kingdom is a general practitioner or a GP practice. Very, very rarely we do make a cancer diagnosis in a patient who's been admitted via emergency. Very often, very rarely, the patient comes to see a hospital consultant and a cancer diagnosis is entertained, and therefore the patient is then referred to the specialist oncology consultant depending on what organ system is involved. Okay, so if it is a female genital tract cancer suspicion, then the patient will be referred to the gynecological team, and the main people in the specialist oncology consultant group are surgeons, oncologists, people who prescribe medicine, and radiotherapists, individuals who also give radiotherapy. So, I do want to take some time to talk about the role of general practitioners in any cancer pathway because we forget that these are the individuals who know you the best. They have your entire history in front of them. They can see your blood counts, they can see all your previous illnesses and your clinical presentation. So, they are the people who are most familiar with your illness. They will know your lifestyle, they will know whether you're a smoker, a drinker, or you have led a very sedentary life, making yourself prone to diabetes, type 2 diabetes, or high blood pressure, all of which are risk factors for cancers. They should always be made familiar with the family history. I think one of the things you must inform your general practitioner if there is a background of family history. As we all know, recently there was a major upset when one of our very favorite Olympian athlete was diagnosed with cancer at a very young age. And what materialized that this was in fact a familial cancer. So a GP will be in the right place to know how a familial cancer should be monitored. The things that are available to general practitioners with regards to investigation are mostly blood based. They cannot ask for a tissue biopsy or use the histopathology service, but they can look at hemoglobin, white cell count, lymphocyte count, monocyte count. All of these can give indication about a patient's illness, especially if it happens to be a blood-borne disease. The other thing they can do is they can measure the enzymes. And last but not the least, the things they can do is look at the tumor markers, which involve CA125, which is done for ovarian cancers, calcium, which can be raised in a range of different cancers, paraproteins, which is a raised immunoglobulin in the blood seen in certain hematological malignancies, and of course, a very useful one, which is PSA. They can monitor PSA in their male patients. So they would be able to do all of these things for the patient to get the ball rolling. What will be the role of pathologist in all of this? Now, a lot of work in hematology and chemical pathology laboratory, all the assessments are done by huge, big machineries. Having said that, the person who looks at the result is a human being. So they will be able to see if a patient's blood counts are outside of the normal parameter. They'll be able to see if the patient has anemia, meaning low hemoglobin, a patient has pancytopenia, which means low neutrophil counts and low platelets, or patient has race counts. All of these three things will trigger for the individual in the hematology laboratory to send a message to the GP asking them for a referral to hematologist. They can also look for cancer related enzymes and cancer related markers, and this is done in chemical pathology. Once again, the signing out individual, if the results are outside of the normal parameter, will immediately bring it to the attention of the general practitioner. I think the tissue diagnosis is something that is not done by the general practitioners. They will then refer the patient on to the hospitals. And one of the very important port of call for every cancer patient would be radiological investigations. The radiologist will decide what is the most appropriate imaging. Chest x rays are still done routinely, but the most important ones that are performed are ultrasound investigations, CT scan, and MRI scan. These have different functions and they relate to different types of illnesses. In the female genital tract, very often they would do MRI scan, whereas diseases of lymph node or lymphomas will dictate CT scan for as primary investigation. The radiologists are also excellent at providing us with the first histological sample. Vast majority of the samples that I report come from the radiologist. They can do targeted biopsy, but that can be done under the under the guidance of ultrasound or CT scan. Targeted biopsy literally means they take out a core of tissue. They can also just put a needle in and pull out some liquid. So that's the difference between cytological specimen and histological specimen. Histological specimen is a biopsy, which is a core of tissue, and fine needle aspirate is just literally fluid, which they can spread on a slide. They can also drain fluid from the chest cavity or from the abdominal cavity. All of these things are various samples that we receive routinely. And every sample that comes to us, quite frankly, the main question is this cancer? So the pathological investigations include blood analysis, fluid analysis, and tissue diagnosis. I've already spoken about the blood analysis. Fluid examination, the tissue that can be drained from the chest cavity is called pleural fluid. Distended abdomen very often is due to ascites, and that can be drained. They can drain an obvious cyst, very often in the breast or in the axillary cavity. Very, very rarely, they have also given me a very interesting sample, which is taken out from the breast implant. So if there's any excessive fluid surrounding a breast implant, they will drain that for me. And very rarely, they'll take out joint fluids. The tissue diagnosis can be done two ways. One, it can be just the liquid sample, which is the aspirate, or a biopsy. So we see a large number of biopsies being done, most of by radiologists from breast, lymph nodes, or solid tumors. So these are the samples that are taken out for diagnosis of cancer. This can be a fluid from the ascites, and very often we make cancer a diagnosis on the ascitic fluid. Very often female genital tract cancer spreads in the peritoneal cavity and produces ascites which can be drained, and we can give you an answer based on that. Aspirates can be taken out of breast, from lymph nodes. And then, of course, the most important form of biopsy that I report routinely are the needle biopsies. Very rarely, a patient can present to accident and emergency unit with a major obstruction. Very often, these are obstruction to the gut, and the surgeon goes in and resects the big obstructing tumor. So, very rarely, the diagnosis of cancer can be made primarily after an emergency surgery for resection of gut. Very often, the surgeon will also go in with the laparoscopy to give us a laparoscopic biopsy. That is really only possible when there is a widespread disease within a cavity. Then this is an important one, the frozen section service. I don't know if any of you have ever heard of this, but sometimes when a patient is on the table and the surgeon finds an unusual abnormality that they're not sure about, they will send the tumor across very, very fast. And then while the patient is still under anesthesia, we will then freeze that tissue, and hence the word frozen section. And then it will become like a cube of frozen tissue, and that will be cut and stained, and we will provide our rough or preliminary answer based on that frozen section. So all of these different things lead to laboratory specimen. So I just want to mention the laboratory process. I think the first and the most important step in this process is the specimen booking in. In United Kingdom, every person has an NHS number and a date of birth, and that's how we identify patients: name, date of birth, and NHS number. And this work in the laboratory is very often done by the junior most person in the department, and it's quite a serious responsibility to carry. So once they've booked in the specimens, then the next stage, a slightly more senior person from the laboratory comes in and sees whether the specimen is very small, can go straight for processing, or it needs to be looked at by histopathologist. And this is a very important step for a histopathologist. Once they have looked at the specimen and decided to describe it in detail, they will take the samples from this big specimen. These samples will then be processed. The processing of this sample is very modern, and we literally can process some samples in 2 hours, whereas some samples take 24 hours. So very much depends. So for breast samples, for example, which has a lot of fat, can take 24 hours. Tiny needle biopsies that I receive from the radiologist for urgent analysis can be done in 2 hours. All of this results in preparation of a tissue block. So the processing by these modern machinery is very, very beautiful current event. These are very well designed, highly successful models. But the main process by which we actually examine the specimen is very old. So this piece of tissue that has now been processed gets embedded in wax block. And this preparation of tissue block, as we call it, believe it or not, goes back to the 15th century. So in the time of Leonardo, there was preparation of tissue block available. So that's how old this process is. And I often wonder whether he actually was involved in creating the tissue blocks. Because as we know, he was interested in human bodies and human structure and structures of the different organs. The next thing that happens to this tissue block, we cut very thin sections out of it. And this is all manual tasks. So far, we have not been able to machinerize any of this. So these are made by our very, very experienced and very dedicated laboratory staff. They will then produce thin sections which will be put on glass slides. And these glass slides will be stained. The traditional two stains that we use are pink and blue. Blue is hematoxylin. And once again, it's fascinating. The hematoxylin, the dye was identified by Spanish in the 19th century in South America. And 200 years later, we are still using that same blue color and with the pink color. So all our slides are stained blue and pink. And depending on the type of tissue we have, the intensity changes, pattern of staining within the nucleus changes. As I have spent last 30 years of my life looking down the microscope at pink and blue slides, it's no surprise that my two favorite colors are pink and blue. So macroscopic examination looks something like this, okay? So this is a big ovarian cyst. It's sitting on a big weighing scale. So I'm trying to figure out how much does it weigh and how much does it measure. The thing, can you see a very beautiful glistening capsular surface? This is very reassuring to a pathologist. I can look at this and say that this is an intact capsule. And very often when I cut into these cysts can weigh up to 4 kilos, almost same weight as a fetus. But when I cut into it, it's basically filled with turbid fluid. It all flows out and the whole thing collapses. That is extremely reassuring to me when I'm examining this. I know that there is no solid tumor lurking here. The capsule is intact. And this means it's a slow growing tumor. It's a slow growing tumor, and very often that means I feel reassured it's non cancer. So I do a fair amount of macroscopic examination in the laboratory, and I would say 85% of the time I can guess accurately the diagnosis. This, on the other hand, folks, is a very different game plan. This is a 6 millimeter core that's been taken out most probably by radiologists, and you can see the variations in the color throughout this. So this would make me think that this is from coming from a patient who already has probably widespread disease in the abdomen, and this will be processed urgently within a 4-hour processing, and I'll be presented with the glass slides. So what is my role? My role first is examination of specimen, examination of screen slides. I have lately started working exclusively on digital images. Then I have to make absolutely certain that I can correlate it with the clinical information and it makes sense. I make my preliminary diagnosis based on the original digital images or the stain slides of hematoxylin and eosin. I can say quite a few things, what kind of cancer it is and what kind of grade it is. So that's the two things we do for all cancers. First of all, we decide what subcategory of cancer it is, because I'm sure you all know there are thousands and thousands of different types of cancers. They begin with they are so well behaved that we very often don't treat them. We call them low grade cancers, to something that makes us jump up and run and grab a phone and discuss it with the clinicians if it is a very aggressive looking cancer. Once we've done that, we will then request additional work. The three main categories of additional work which are done by histopathologists. The first is special stains. These go back again hundreds of years while we've been doing special stains. And then 1980 onwards, a very important investigation is called immunohistochemistry. And last but not the least is the molecular testing. So before I go any further, I would like to talk about subspecialization by histopathologists. Almost all the histopathologists in big hospitals will choose and get dedicated to an organ system. As I've already said, I have specialized for the last 29 years in working in gynecological cancer and hematopathology, which is blood, bone marrow based diseases. Why are we doing this? There was a time when most people were general pathologists because of very marked expansion in our knowledge, which makes it necessary that we stay focused on an organ system. I mean, I sometimes think two is quite a challenge. Classification of cancers is done by guidance provided by WHO. WHO will employ a group of histopathologists every few years to update our knowledge, provide new categories, and that is all based on huge amount of research that goes on a daily basis. So the people writing these books and textbooks have got to be specialists in their field and have got to be very focused on the current research programs. In histopathologists, we don't just provide diagnosis of cancer. We provide so much additional information, which is the prognostic criteria. Prognosis is different from diagnosis. Prognosis means we can tell likely course of the disease, and this also involves staging of cancer in the big resection specimen. So what I mean by that is if I say to my gynae surgeon that this patient has grade 1 endometrial cancer and it is stage 1A after looking at your resection specimen, the gynae surgeon, the radiologist, radiotherapist, and the oncologist will know straight away that this is very good news for the patient. 95% of these patients will need no further treatment and can be monitored but will not need chemotherapy or radiotherapy. Whereas on the other hand, if I say to my gynae surgeon that this is a grade 3 cancer and stage 2 cancer, then they know that this patient will now need radiotherapy and chemotherapy. So just by giving them the diagnosis, grading, and staging, I can actually predict what's going to happen to the patient. And that is the main role of histopathologist. And because every organ system is so complex, we have to subspecialize to make sure we provide the best information for our surgeons. This also increases your scope for research because if you're working in a specialist field, then it makes it much more easy for you to ask questions and try and find answers for that. All of these are monitored by Royal College of Pathologists. They make us undergo continuing professional development, continuing medical education programs, and the EQA programs, which test our knowledge. And I have a big EQA meeting tomorrow for the gynae pathology, where I'll be testing my answers against my mentors and my colleagues from across the country. So, therefore, the subspecialization is important, and cancer diagnosis in a big hospitals are typically made by individuals who are specialized in that field. So, what are the things I'm looking out for as a pathologist with regards to cancer? I'm sure you have heard this term, invasion. We use the word with regards to cancer very often. I'm just going to check the time, see how I'm doing. 30 minutes. So we always talk about invasion. Invasion we used to relate to armies, didn't we? And conquering armies which invaded a country. Cancer is very similar in many ways. So cancer cells will continuously proliferate or divide, become from 2 to 4 and 4 to 8, which is not normally what happens in human body because we have checkpoints. We stop cells from proliferating, but cancer cells do not follow the checkpoints. The other thing the cancer cells do not do, they do not respect boundaries. They will spill out. They will go and invade, infiltrate the surrounding connective tissue. To do this, they need three things. They need the blood supply and they need the connective tissue stroma. The blood supply is absolutely vital. Without the blood supply, the tumor will die. And the connective tissue framework is important because they need to grow across the scaffolding of connective tissue and infiltrate the surrounding tissue. And some cancers are very clever. They produce huge amount of connective tissue stroma, and we refer to that as desmoplastic stroma. As you all know, medical literature is very much influenced by Greek and Latin language, none more so than histopathologists. We love our use of Greek and Latin language, and I'll let you on to another secret. We pathologists love the use of terms which come from food. So we will often describe a tumor has a consistency of a pear and numerous other such. We talk about anchovy sauce. That's a very typical pathological thing to equate everything to food. And as the malignant cells need blood supply, they grow out of their blood supply, and that means part of the tumor dies. So, cell death or necrosis, as we call it, is a very big feature of cancer cells. So, if I get given a biopsy that just shows necrosis, I may not be able to give a confident diagnosis, but I'll definitely say to the clinicians, this is necrosis, which means this most probably cancer. And another very important feature of cancer is it does not just have malignant cancer cells. It's admixed with blood vessels, connective tissue stroma, and very importantly, immune response. Every cancer will provoke immune response. Different cancers have different degree of immune response they provoke. By that, I mean the tumor is extensively infiltrated by immune cells, which include macrophages and lymphocytes. So, immune, and as we know now, that we take great advantage of this fact that the lymphocytes infiltrating the tumor can be trained to recognize malignant cells. So, the lymphocytes in human body are divided into two main categories: B lymphocytes and T lymphocytes. And we very often train our T lymphocytes to recognize the tumor cells. So, a lot is learned by pathologists by looking at not just the cancer cells, but what is the background, what is the stroma like, how much of necrosis is there, and what is the immune response to that tumor. So, at this point, maybe I should mention a relationship of cancer with immune system. Immune system is there to protect us from infections. And as I just said, they also help us recognize anything that is malignant or infiltrative in the body. Inborn error of immunity, which we diagnose in newborn children, accounts for patients who have underlying immune disorders, and these patients are much more prone to getting second cancers. We have now identified more than 450 different types of conditions, and this is mostly thanks to the Human Genome Project. The other thing that we know now is that 20% of the population has autoimmune disorder. Autoimmune diseases means your immune system fails to recognize the self from non-self and therefore can actually attack your own body. Patients with autoimmune diseases are also more prone to getting cancers. The other bad news is after the age of 50, the immunity status starts to decrease and we go into state of immune senescence, making us more prone to getting secondary infections. Cancer treatment itself compromises immunity, and viral driven cancers are common in individuals with low immunity. So, low immunity can give rise to second cancers, and they're very often secondary to viruses. For example, in patients who have HIV driven HIV can are much more prone to getting human papilloma virus driven cervix cancers. And elderly patients are much more likely to get Epstein Barr virus driven aggressive lymphomas. So just want to now share with you some of the preparations that I would be examining. The first is the cytology. So as I said earlier, cytology basically means there is just fluid. It's like a soup of cells. And then it will be my job to look at the soup of cells and identify what's normal from what's abnormal. This is what we typically do from the fluid that's drained from the pleural cavities, fluid that's drained from the abdominal cavities, fluid that's taken out of lymph nodes, breast. So this on the right hand side is the what normal can look like. These are the sheets of cells and these are the lining cells of the peritoneal cavity. We call them mesothelium. And you can see they're very well organized, very regular shaped nuclei, well defined cytoplasms, and this is what normal would look like. This, on the other hand, is an hematoxylin and eosin stained section of a clump of cells which look very abnormal. Every cell is different. Every nucleus is different. These are the nuclei, and you can see the characteristics are different. And I can't show them to you here, but these two are probably mitotic figures. So I can see straight away a very abnormal population which is showing mitotic activity, and this will make me think that this probably is coming from a cancer sample. This, on the other hand, is tissue. And you can see straight away that we can see clumps of cells well arranged, and this is anatomical configuration or the in the background of the tissue. Once again, pink and blue, but can you see the differences in the staining? This can be from different laboratories, and this can also be different tissues. And all the blue dots we see here are nuclei. The reason this will make me think straight away this is cancer is because this little island of cells should not even be here. This is an invasive tumor. It's invading the surrounding connective tissue stroma. Same thing is happening here. So when I see a section like this, I can say quite confidently to my colleagues, this is an invasive squamous cell carcinoma. Or I can then go ahead and order some second set of stainings, and one of them are the special stains. Special stains were very important, say in 70s and 80s when we did not have access to other stains. So we could do mucin stains for mucin secreting tumors. So these are mostly gastrointestinal tumors coming out of the gastrointestinal tract, which often are mucin secreting. We also do special stains regularly and religiously in any infective case. We can look at this and see if it has got TB organisms, which are the acid-fast bacilli, and we can diagnose infections. And I am an old-fashioned pathologist, so I use special stains to look at the structure of my biopsy and see whether that gives me a hint. This is where a huge amount of advance has been made in the diagnostic world in the histopathology. And this is immunohistochemistry. We can look at a protein or a marker in the nucleus, in the cytoplasm, or on the surface of the cell. And we basically can identify some very important features. We can classify the tumors based on the immunohistochemistry. We can say this is an epithelial malignancy, and about vast majority of the tumors in human bodies are epithelial in nature. This will be tumors taken out of breast, lung, stomach, pancreas, prostate. All of these are epithelial tumors. And of course, my specialist area being hematology, I would be able to diagnose hematological malignancy based on immunohistochemistry. In fact, vast majority of hematological malignancies cannot be accurately classified without immunohistochemistry because it's quite advanced and the immune system is quite complex. And of course, malignant melanoma is a big mimicker. Malignant melanomas can arise almost anywhere and can mimic any morphology. And therefore, it's very important to do immunohistochemical profiles of tumors to say confidently what that tumor is. The second thing immunohistochemistry helps us do is recognize some special features which will influence the patient's prognosis, how the tumor is going to behave, and what treatment protocols we can offer. I'm particularly biased about proliferating capacity of tumors. I use this marker quite religiously because I can tell how fast a tumor is proliferating. Although I can see mitotic figures quite easily on H&E sections, but this will give me a special insight into a tumor. Some of the most proliferative tumors in human body are seen in young people, and some of the most proliferative tumor in human bodies are things like Burkitt lymphoma, and in that the amount of proliferation is key to diagnosis. And when you see a tumor that is showing almost 100% proliferation, you tell your clinicians and they have to get on with treatment because these tumors grow at an enormous rate. And last but not the least, I can tell whether the tumor is associated with a virus. And the two very important viruses that I deal with a lot is Epstein-Barr virus and human papilloma virus. Epstein-Barr virus causes glandular fever, and most of us are exposed to EBV virus by the time we are 10. So 95% of us have been exposed to EBV and have got latent EBV infection lurking in all of us. When you cross a stage in your life when your immune system goes down, then this EBV infection can actually manifest as second infection, reinfection, or in very unfortunate cases as second malignancies. Similarly, human papilloma virus, as we all know, is one of the big causes of cervix cancers. And therefore, we have currently vaccine program for human papilloma virus and a screening program for human papilloma virus in women. So all of this can be achieved, and this whole field is expanding at amazing rate. And this has all started since 1980. So in the last 40 years, we've seen a great expansion. We literally get inundated with new markers literally on a weekly basis. And this is where comes in all the research. When you attend a meeting, you're informed of all the new markers that you can do. Once I made up my mind that this is what I think this tumor is, then I take it to the multidisciplinary team meeting. And this, folks, is the top table. This is my place on the top table where I can discuss the patient's diagnosis and give information about the prognosis, how I think the tumor is going to behave. So the multidisciplinary team meeting for cancer includes histopathologist who offers the diagnosis, radiologist who also offers the diagnosis and gives an insight into how widespread the disease is. We do regularly do large number of PET scans to see how widespread cancer is. The surgeon is always there because they need to know what they've given me and what sense I made of it, whether a tumor is completely excised or not. Oncologists are there because they're interested in knowing what diagnosis and what treatment pathway the patient is going to go. Radiotherapists are there, nursing staff is there, and if you work in a big team like I do, you also meet a psychologist and epidemiologist. At this point, we decide on patient's treatment pathway. We discuss every new patient in detail. So I will be providing intersection specimens, not just the diagnosis. I'll also be giving them information about the staging. I'll provide information about how extensive the blood blood invasion is, which is a very important factor, which is called vascular invasion. The tumors will find their way into blood vessels and will go into the lungs or kidneys and liver, or find their way into the lymph nodes. So by giving them information about blood invasion, vascular invasion, I will be giving them very important prognostic marker. I'll also be able to tell them any basic immunohistochemistry that I've done so far. And important things will be my analysis of Lynch syndrome possibility in a patient with endometrial cancer or mutation in a very important gene called P53. We also will discuss patients who are already on treatment pathways to make sure that the disease is responding to chemotherapy and that decisions for specific treatment and any further investigations are made in the multidisciplinary team meetings. And then, last but not the least, we will discuss the molecular assessment of a patient. So, molecular assessment, what is baffling these days is amount of information we can provide from a very small biopsy. That 6 millimeter biopsy I showed you earlier is enough. There will be enough material to do immunohistochemistry and then extract the DNA to and analyze the different genes. Currently, the machines we are using in United Kingdom will analyze up to 500 different genes, and then we will be able to investigate the genes that we are interested in. These will include germline or somatic genetic variants. And this, the best example of this is BRCA. So you can have a BRCA abnormality that you have inherited or a familial BRCA abnormality, or sometimes it's just the tumor. Just the tumor has an underlying BRCA abnormality. A tumor that has underlying BRCA abnormality has got different response to chemotherapy. So these things are very important. So all patients who have fallopian tube or ovarian cancers will immediately be sent for germline BRCA, for BRCA analysis in the tumor, and if necessary, germline analysis on blood. We also look at epigenetic signatures, transcriptional changes, and proteomic signatures. A vast majority of complex molecular work is done. This does take time. The turnaround time is not as fast as the histopathology diagnosis and immunohistochemistry diagnosis. But this will change. Our machines and individuals are becoming much more advanced in this investigations as well. So I just want to give you an example of one of my recent cases. A 21-year-old female was admitted straight into ITU, and as I said, that does happen sometimes. She was cachexic. She did not look like somebody from 2024, a young, healthy female. She was skin and bones and had a very distended abdomen. So the fluid was drained from the abdomen. She also had range of abnormalities. Her sodium, potassium levels were incorrect. So ITU, we're really focusing on what we call stabilizing this patient. And then what happens is a huge big range of email communication starts, which starts with the ITU consultants, the radiologist. And then when the radiologist said that they thought that this was a disseminated or widespread ovarian cancer, ovarian surgeons were called in. The moment a gynecological surgeon was called in, they immediately messaged me and said that we have drained some fluid and done a biopsy. Can you please look out for this? So the biopsy had been performed at this point when I became involved in the. So I, at this stage, had this patient's name and date of birth. And so I went into our database to investigate and find out what was happening to this young girl's biopsy. So I put in her date of birth and her surname. Much to my surprise, two names appeared, both with the same date of birth, same address, and slightly same surnames, but slightly different names. So my first concern was we have booked in incorrectly. We have booked in same patient twice with two different names. And this can happen, and you have to be very careful when you're looking at your biopsy specimens. I immediately responded to the whole email chain and said, does this patient have a twin sister? And you know who gives me an instant answer? The nurses. The nursing staff are always on top of these things, this kind of information. Immediately, an answer came back, yes, she has a twin sister. So I managed to find the biopsy and I looked at the biopsy. And much to my surprise, I made a diagnosis of a very rare ovarian cancer. Last time I diagnosed this rare ovarian cancer was almost 10 years ago. So this was a rare ovarian cancer, and it was also a diagnosis that was associated with high blood calcium levels. So once again, I asked the email correspondence, does this patient have high blood calcium? And they informed me that when she was admitted, she had very high blood calcium. And now I have made a rare cancer diagnosis, which I haven't made in 10 years. And I also know now, with our current knowledge, with the current WHO guidance, that this tumor is associated with very poor prognosis. By that, I mean it does not respond to the current treatment protocols we have. And another very important feature of this cancer, it has an underlying abnormality, a genetic abnormality. This genetic abnormality can be, once again, a familial abnormality, or it can be just in the tumor. So we immediately arrange for the patient's blood and the tissue sample to be sent for very urgent analysis by the molecular geneticist. They can be very helpful in times like this. And this was rushed through the genetics analysis, and they confirmed the diagnosis that I had made. This was a very rare disease, and it has a very funny name. It's a small cell carcinoma of hypercalcemia type. But the underlying abnormality is in a gene called SMARCA4. And in this patient, the SMARCA4 was in fact a familial abnormality. It was in her blood and in her tumor. I already knew at this point that she had a twin sister. So last time when I had this sort of abnormality 10 years ago, the entire family was investigated. Two sisters, unfortunately, died 10 years apart from each other. So I had first seen the biopsy 20 years ago from one sister, 10 years ago from the second sister, and we had investigated that entire family. And this is a very bittersweet moment, when you make a diagnosis like that, based on a very age old tradition of hematoxylin and eosin, based on your very clear conversation with the ITU consultants and the nursing staff. It's a rare disease. You get it right, it has got a genetic abnormalities, but you know that the outlook for the patient is poor and the entire family now needs investigating. So laboratory services where I work are like secret services. We are always open for business, around the clock services provided. Attention to detail is absolutely paramount while we are registering the service and registering the patient so the patient details are accurate. We have to make absolutely sure everything matches with the clinical information. We provide very urgent specimen requests, which we can deal within hours, sometimes as a frozen section and sometimes as urgent cases, especially in young patients, so that we can start appropriate further work, which will be immunohistochemistry or molecular analysis. And all the time, I like to think we are constantly involved in a dialogue with our clinical teams, which can be a surgeon, which can be ITU consultants, or which can be oncologist. And then we make sure that all the appropriate samples go across to genetics lab for sometimes just for storage and sometimes to provide us the information that we need in these patients for further management of these patients. So with that, I'll end my talk and I look forward to your questions.
That is so much information. Thank you so much. I think people are going to be watching this again and again to absorb everything. That was great. Thank you. We do have quite a few questions actually. To start off with, we've got, it's interesting seeing a face to the results, which makes me think that maybe there's some human error in staging and I assume diagnosis as well. So can you give a comment on the human error, if it's there, what you do about it, what controls there are?
Yes, I think I'm so glad you asked that question because there is going to be human error. We are human beings. And so the moment, suppose very often I would review my own cases. Vast majority of the time, I will agree with my report, hopefully. But there will be times when I'll say, hang on, let me just discuss it with the clinicians to make sure that this is making sense. So there will be changes to the diagnosis and there will be human errors as well. And very important it is to, when I made my first error, I remember the senior pathologist said to me, learn from this, eat the largest humble pie you can find, but then move on. So those are the three important things: eat the humble pie, learn from it, and then make sure that you learn enough about it so you don't make that error again. But human beings are human beings, there will be errors made.
And Jane says, with so many changes, how do we know that all pathologists are up to date?
Yes, another very important question. So that's where the Royal College of Pathologists comes in. So we get our appraisal every year. Every year, a senior member of the staff will be appraising us, and we will presenting to that person what have we done in that year, which will take into account our continuing medical education and our EQA performance. So as I said, tomorrow I'll sit down in a virtual meeting. There'll be, I think, hundreds of us from across the UK, where we look at our answers and compare it with how everybody else answers the same biopsy specimen will be looked at by 500 pathologists, and we will match our answers with each other. So yes, there is a lot of inbuilt guidance from the Royal Colleges, GMC. So this appraisal, there is a 360-degree feedback. Our clinicians can give information about us anonymously and say whether we are doing a good job or not.
So this is UK. Do you know what it's like around the world? Canada, Australia,
We all
America.
do more or less the same things. They probably don't call them royal colleges like we do. And but same sort of thing happens all over. Similar process,
Yeah.
monitored by GMC and the Royal College.
Okay. And then we also have a question. Um, if both radiologists and pathologists make the diagnosis, why do you need both?
In the MDT,
Mm.
yeah, we do slightly different things. So pathologist will make a tissue diagnosis. I'll say this is a squamous cell cancer. Radiologist doesn't do that. He said this is lung cancer. He said this lung cancer is arising in this lung and is spreading to this lymph node. And if I don't have the lymph node biopsy, I will not be able to say it's spread to the lymph node. That's his job. So I'll be able to make a tissue diagnosis, and he will give the information about how widespread it is. Has it produced a reaction in the pleural cavity? Is there fluid, or is it gone to the brain? Because I don't see these things, whereas he does.
So
So
you
we
can
will be
say what it is, and he says where it is.
yes, where it is and
Radiologist
how
will say where it
widespread it
is,
is.
and you
Yeah,
say what it is. Can
yeah.
you comment a bit? That's all the questions. We've got a tiny little bit of time left, so if anybody else wants to ask a question, that would be great. But I've got a question: whether you can comment on staging. How easy is it to define between the different stages? Because I imagine that's quite important in treatment,
Yeah.
the staging. So
Treatment is
yeah,
very much modulated by the staging. So two ways of
yeah.
staging. One is the surgeon takes out. So for example, let me give you an example of endometrial cancer. Yeah. The
Mm.
surgeon takes out the uterus, fallopian tubes, ovaries, and gives them all to me. My job is to see where the tumor is. Is it just a small focus, or is the tumor gone deep into the wall of the uterus? Has it breached the wall of the uterus and gone out? Has it already spread to the ovaries? And when the surgeon takes it out, he or she can see whether it's already spread into peritoneal cavity or not. So that is pathological staging, okay? Then there is radiological staging. The radiologist would have done the PET scan by this stage and will be able to say if the tumor has in fact spread to the lung, has gone to the brain. So the two types of staging takes place, and one is pathologists doing the staging. So when we write our data sets, which we are mandatory to do, we will in the data set write down how widespread the tumor is, and we'll give pathological stage. The radiologists will do radiological stage, and in the MDT, we'll come together and agree on the stage.
And I imagine you can see stuff that the radiologist can't, because if you see
Yes,
it's
very
gone
true.
through the wall, but he can't find it anywhere, you know that it's somewhere else.
Yes. Yes,
Yeah,
which I can see it's gone into the blood vessels. I can
yeah.
see is breaching the uterine wall. And radiologists can be very sensitive people, by the way, folks, almost as sensitive as the surgeons. So you have to be very careful not to disagree with them too often.
Well, absolutely fascinating. Who actually does the I can't say worst job or most difficult job, but whose job is it to tell the patient, and how difficult is it to let the patient know, especially when it's the prognosis is not good?
Yeah, the two sets of people. The surgeons have to tell the patients. They very often will come out of theater and say, "We took out all of this from you, and we've even completely cleared out your." I mean, the amount of surgery the gynecologists do, they take practically half the pelvic organs out, and they will say, "We've taken everything out, and now it's for the pathologist to tell where it is." And then they will offer after the MDT discussion. They'll meet up with the patient again, say, we've discussed your case, and this is what it is. This is the tumor diagnosis. This is the staging for your tumor. And then so they'll give them the diagnosis. Sometimes, if it's just a biopsy, so if it's not a big surgical resection, but a small biopsy, laparoscopic biopsy, or image-guided biopsy, it's usually the oncologist. They will go to patient and say, we've looked at your biopsy and discussed it, and this is what the diagnosis is. So those are the
Right.
two sets of patients. Pathologists never do it.
Mm. From my,
Hematologists do for their own patients.
yeah, I've never, no, I'm just thinking from personal experience and family and people that I've known who've had cancer, it never seems to be the oncologist, which is what I would have expected. You know, it always seems to be,
The
well,
surgeons. Yes,
well,
it
the
very much
surgeon, even
depends.
if the surgeon doesn't do anything, it seems to be the surgeon.
Yeah,
Yeah.
hematologists will give diagnosis for their own patients. So
Oh, yeah,
this will be lymph
hematology.
node biopsies or the bone marrow biopsies, they'll tell the patients. And they're
Mm,
also involved in the diagnosis. So this is a slightly different scenario when a hematologist does a bone marrow biopsy.
mm,
They
mm,
will look at the aspirate, they'll send it for flow cytometry and genetics analysis, but I will be looking at the trophine biopsies. And sometimes my assessment can be different from theirs.
mm, mm.
So this is a slightly awkward because they would like their patients to get cured every time, and I may not be always able to give them that answer. So there is this slight difference when you're also treating a patient and diagnosing a patient.
Oh,
You
right.
always want them to.
Yeah, yeah. With hematology, do you get a lot of blood transplants then? Bone
Yes,
marrow blood
because I work
transplants
in
and
a
things like
center
that.
for transplant, I do look at a lot of trophines which are done for post-transplant patients.
Mm, mm, okay. Well, that's for perfect timing. So much information. I'm sure people are going to be watching again and again and again. I'm going to switch off the recording, but don't go away.